Assalamu alaikum. I am Dr. Muhammad Ali Rabbani and I will be your guide in the next lecture in the series of gross anatomy of upper limb. Today we are going to discuss the osteology of clavicle bone. Okay, the clavicle bone, it is a part of the shoulder girdle or pelvic girdle. As you might already remember that shoulder girdle, pelvic girdle consisted of two bones, clavicle in front, scapula on the back. It is the only bone of the upper limb of this appendicular skeleton that is making a physical joint with the axial skeleton, that is making a joint with the sternum here. And as you can see, scapula does not make a physical connection or bony joint with the bone of the axial skeleton. Okay, it is peculiar in a number of ways. It is the only long bone in the body that is actually horizontally placed. All the rest of the long bones, you can get the examples of all the long bones of the upper limb. These are vertically, longitudinally placed. This is the only bone that is horizontally placed. It has other unique features like it is the bone that is uh, on present just below the scale. You can feel it right here. Even if you are wearing a wide neck shirt, you can see this collarbone right here, especially if you are lean. This is the bone that develops both from membranous ossification and cartilaginous ossification. It is the bone that is first to start ossifying as early as fifth week of intraembryonic life, and its last phase of bone development, that is the fusion of the secondary ossification centers with the primary ossification center, it is most late in the body, that is as long as 30 mid 30s years in your body. It does not contain any bone marrow. Okay, let's talk about its anatomical position and its function. It is horizontally placed long bone. It is making joint with the sternum. So this is called sternoclavicular joint. To be more specific, this part of the sternum, it is called manubrium. This part is called manubrium. So it is also called manubrioclavicular joint, but usually sternoclavicular joint is the commonly used term. And here it makes a part joint with the part of the clavicle that is part of the scapula that is projecting here. This is called the acromion process. This raised portion of the scapula, this is called acromion. So this is called acromioclavicular joint between the acromion of scapula here and clavicle here. It is horizontally placed. It keeps your arms, shoulder away from the center so you can have a better mobility and possibility of movement. And it is one of the major weight bearing bones of the body. Let me show you the transmission line of forces. Like if you put your hand on the table and you try to put your weight on the body of your weight, it transmits in the following manner. If you, let's say, I put my this palm on the table and I put my weight here. So it travels like this. It is transmitted from the palm across the wrist to the radius bone. And if you can see the between the radius and ulna, there is interosseous membrane. It is then transmitted between these two bones from radius to ulna through interosseous membrane. That is transmitted above through ulna. Ulna has a very strong, very big connection in a form of elbow joint with the humerus. It is transmitted there, and as you move upon to clavicle, here is the interesting part that I wanted to actually show you. The joint itself, it's not the most weight bearing part or the prominent part. Here you can see there are two sets of very strong ligaments that are present. One is this set of ligaments between the coracoid process of scapula, this projection, this is called coracoid process. This is called the coracoid process. The other one is clavicle, so this is called coracoclavicular ligament. So this is called coracoclavicular ligament. We will revise these as we move along. And then here is a ligament that is not very cleanly shown. Let me add that to the picture. Sternoclavicular ligament. Let me add that to the picture. On the right side, there is sternoclavicular ligament. Actually, it's right here in front of my eyes. So this is sternoclavicular ligament. So these are the ligaments that are responsible for transmission of forces. So it comes as the forces they are transmitted through here and then here to the uh, axial skeleton. The point I'm trying to make is these ligaments are so strong that if an excessive force is transmitted up your upper limb, like if you fall face forward and try to catch your fall by hand, and if this fall is too high or too much for your bones to bear, it usually called fracture in the middle of the clavicle. It usually does not cause dislocation at acromioclavicular joint or sternoclavicular joint, but it causes the break between the two ligaments because how strong these ligaments are. So in clavicle, you will not find fractures much more commonly, but you will be discussing not dislocation much more frequently, but you will see fractures. Okay, now let us talk about the clavicle bone in itself. Let me get one thing straight. Let us isolate the clavicle and hide other things. So we are here. Let me zoom in. So you are seeing the clavicle isolated. It is the clavicle of the right side. I have put it in anatomical position. Let me zoom it again. Okay. Now, the first question is what are its parts? Before going into that, if we're looking at the bone in isolated form, it is very difficult to know which side bone it is. It is the bone of the right side or the left side. You already know because you saw the skeleton as a whole, but what if you are given the bone alone? So while trying to find the side of the bone, you have to differentiate between the three axes. Like when differentiating the side of the bone, you don't know it. So try to find out what is anterior versus posterior, which is anterior, which is posterior, which is superior, which is inferior, and what is medial and what is lateral. Let's try to figure out them one by one so we can find out which side bone this is. So to figure out which side is superior and which side is inferior, look at both the surfaces. This is the superior surface and this is the inferior surface. Notice anything special different between the two? The inferior surface has these things. It has this groove. This is called subclavian groove. This is called subclavian groove. This is one thing, and it has these parts. This is an ovoid impression on the medial aspect, and then it will be more prominent if I tilt it a little. This prominence, this prominence, this is the conoid tubercle. This is conoid tubercle, and on just lateral to it, this raised line, you can feel it right here. If I tilt it, you can feel it right here. Let me show you again. This is the this line. This is the conoid tubercle, and this ridge is the trapezoid ridge. So this is the conoid tubercle. This line is the trapezoid ridge. So these are the things that will help you distinguish them from the superior and inferior surface. So the superior surface has does not have any very prominent features. It is relatively smooth. The inferior surface will have subclavian groove in the middle, impression for the sternoclavicular ligament medially, and conoid tubercle and trapezoid ridge laterally. So you identified which is the superior surface, which is the inferior surface. Now let's see which is the medial end, which is the lateral end. This is the medial end. This is relatively having relative equal dimensions in anteroposterior in both the axes. It is having relatively similar dimensions in this direction and this direction. So this is quadrilateral in shape. Quadrilateral in shape. So this is the medial end, or as it is joining with the sternum, this is also called sternal end. This is the medial end. Let us look at it is the sternal end, and let us look on the other side. This is relatively flattened. You can see it is flattened from above downwards, so it has more length in horizontal direction than as in the vertical direction. This is flattened, like it is flattened like this. So it is making it is the lateral end. It is the lateral end. It is the acromial end. So we talked about, we found out that it is the we found about its laterality on the right side or the left side. So let me get it again. So here is the superior above, this is the inferior below, this is the lateral, this is the medial. If you got these things straight, then the anterior and posterior can be very well defined if you look at them from above direction. So I am looking at this bone from the above direction. This is the medial end. This is the lateral end. If you see this part, the medial part that is convex anteriorly, and this is convex anteriorly. This is the 2/3, medial 2/3, and this is the lateral 1/3. It is convex anteriorly, and this is concave posteriorly, and the lateral part is opposite. It is convex posteriorly and concave anteriorly. So this is how you find out. If it had been a bone of the left side, those would have been opposite. So this is anterior and this is posterior side. So this is how you find out which side of it. If you are given a bone, just figure out these three things. Which is the medial end? The quadrilateral one. Which is the lateral one? The flat one. Which is the superior surface? The smooth one. Which is the inferior surface? The one with groove and conoid trapezoid ridge. Now, which side does it fit, on the medial side or lateral side? It will fit on the medial right side skeleton, as it has anterior convexity at this side. So you can visualize this on a skeleton. You will see, okay, it does fit on this side. If I compare it with the clavicle on the other side, all the other features will be same, but you will see this medial end convex forward and lateral end, it will give way whether it is on the right side or on the left side. So this is the side determination of the clavicle. Now let us talk about its feature. Let us isolate it again. Okay, let us talk about its ends parts. When talking about its parts, it has the following parts. Simply speaking, the two ends. We just talked about the sternal, quadrilateral, the acromial, and in the middle there is a shaft. The shaft we just talked about, it is divided into medial 1/3 and lateral, medial 2/3 and lateral 1/3. The shaft, if we talk about, it can be divided into anterior and posterior borders and superior and inferior surfaces. When talking more specifically about the parts. Let's talk about the parts individually. Let us talk about the lateral one third. This is the lateral one third. It is relatively flattened above downwards as we saw that. So the anterior one will be called anterior border. This red line, this will be called anterior border. And the one that is behind that will be called posterior border. The one that is above that will be called superior surface. And the one that will be called inferior surface. If even for the medial one third, as the bone is no longer that much flat as it was on the lateral surface, so some books including BD Chaurasia, they change the terminology. Rather than saying the anterior border, they say anterior surface. On the medial one third, they say anterior surface, posterior surface, superior surface, and inferior surface. So these are the different things, different surfaces and borders. Two anterior and posterior borders. It's very simple to follow that, and the two surfaces. Let us talk about the different bony features that are present here in the lateral one third. Lateral one third is a flattened one. Uh, when you will discuss all the four surfaces or two borders and three surfaces. Let us go through them one by one. The anterior border. The anterior border is concave forwards. You can see it is empty, concave forwards. The posterior border is convex backwards. As simple as that. The superior surface, it is totally subcutaneous. You can feel it right here, and it is relatively smooth. You will not find many bony features right there. And the inferior surface, you will find two prominent bony features in the lateral one third. The prominence, that is the conoid tubercle, and this raised elevated ridge, that is called trapezoid line or trapezoid ridge. These will give attachment to the two parts of the coracoclavicular ligaments by the same name, conoid and trapezoid parts. Let us see the medial half. Medial one two third, the anterior surface. Now, the anterior surface will be convex forward. The posterior surface will be concave backwards. The superior surface will be majorly smooth. It will have a little rough part on the medial end where there is an attachment of the muscle. I will show you them in the next section. And the inferior surface. Okay, let's see the inferior surface. Inferior surface has two main prominent features. It has this subclavian groove and this ovoid impression for the sternoclavicular ligament. You can see them a little more easily if I remove this labeling. So this area, this depression is called subclavian groove, and this one is called, this is the ovoid impression for sternoclavicular ligament. Not very much clear. It is little, you might be able to see right here. Here you might be able to see this small foramen, this one. This is the opening for the artery that is feeding the clavicle, that is called nutrient artery. That is called nutrient artery. Okay. So that is mostly all about the features. We talked about the ends. These are quadrangular and flattened. Okay, let us talk about the different muscles that are attached, different attachments to these bones. Okay, so this is image of the different muscles. Let me set it up a little more. Okay, let us talk about the origin and insertion. So what I have done is I have made the clavicle more prominent. In the red, you will see the origins of the muscle. In the blue, you will see the insertion of the muscle. You can ignore the rest of the red and blue labeling in the skeleton. We will go through them one by one. Talking about the anterior surface. Anterior surface in front of the medial two-third, there is an attachment of pectoralis major muscle. This is the pectoralis major muscle that you can see in the front of your chest. Those who are familiar with bodybuilding, they are very much interested in developing their pecs. So these are the pecs, pectoralis major muscle. So this is on when talk I'm not talking about its rest of the attachment to the clavicle. It is attached to the anterior surface of the medial two-third. So this is the attachment of pectoralis major. When talking about the let's continue with the medial two-third. On the superior surface, here you can see on the superior surface there is an attachment to the muscle that is the sternocleidomastoid. This is the sternocleidomastoid. It will be more prominent. Let me show you here. It will be not be very visible in the skeleton. Let me show you right here. Because it's connects to the axial skeleton, so it was not shown in the upper limb model only. So this will be the sternocleidomastoid, this muscle. So you can put your head like this, and this is the muscle that is sternocleidomastoid. Its name is sterno, attached to the sternum, clado, attached to the clavicle, and mastoid, it is attached to the mastoid part of the sternum of the skull. So let us stick to the clavicle here. So the sternal head, so clavicular head, arises from the superior surface of the clavicle near the medial end. So this is the muscle of the sternocleidomastoid. Let us continue on the medial aspect. There is no muscle arising from the posterior surface. Um, there is, however, muscle arising from the inferior surface. This is the inferior surface. You saw the subclavian groove. The subclavian groove gets its name from this muscle that is called the subclavius muscle. This muscle basically runs between the clavicle and the first rib. This is subclavius muscle. So these are the attachments of the muscle in the medial two-third. Medial two-third, we talked about pec major, sternocleidomastoid, and yes, then there is costoclavicular ligament too. We talked about costoclavicular ligament. I showed you it right here. So then there is these two ligaments, costoclavicular ligament. So they are from this area. Um, I will show you this area. This is the attachment for the costoclavicular ligament. Let me try to get it up. Here is the ligament. This ligament runs from the lower end of the clavicle to the costal cartilage of the first rib. So here is the costoclavicular ligament. So it runs from this medial aspect to here. So these are the structures that are attached to the medial aspect. Anterior surface two-third, it is giving rise to the pec major. The posterior surface is not giving rise to anything else. The superior surface, it is giving rise to this sternocleidomastoid clavicular head. The inferior surface is giving rise to the subclavius muscle, and in this region, it is giving rise to costoclavicular ligament. And apart from it, if you have to go into a little more detail, these the fascia covering the muscles are obviously attached with these also. So the fascia covering the neck, it's enclosing the sternocleidomastoid. So this fascia encloses the attachment of the sternocleidomastoid like this, like this. It continues all the way, space between the two, and then it encloses the space between the trapezius. Similar is true for the attachments of the pectoralis muscle, its fascia covering, and around the subclavius attachment, there is a fascia, clavipectoral fascia, that is surrounding the muscle gets attached to the bone also. So these are the attachments. And when talking about the ends, in addition to these ligaments, Costoclavicular ligament was attached to the inferior surface. The capsule of the sternoclavicular joint, it attached to this margin. This is attached to this margin. Apart, there are other connections also, but these are the major ones. I think I've already gone into much detail. On the lateral one third, the anterior surface, it gives origin to deltoid muscle. Here you can see the deltoid muscle. It is the one that is making the prominence of your shoulder. So it anterior two-third, apart from other origins, this is the origin of the deltoid. The posterior one third, it will be again more visible in the model of complete body model. You don't have to memorize the whole origin in a session right now, but this is a trapezius muscle that is spread across whole of your back. It is connecting a lot of your axial skeleton to this clavicle. So this is the clavicular end. So the clavicle is giving attachment anteriorly to the deltoid and posteriorly to the trapezius muscle. And on the lateral end, it is giving attachment to this capsule of the acromioclavicular joint, and inferiorly, you saw those trapezoid ridge and conoid tubercle, and these are giving attachment to ligaments of the same name. So here is the conoid ligament getting attached to this conoid tubercle, and this is the trapezoid ligament getting attached to in long line trapezoid ridge. So these are all the attachments of the clavicle we talked about. Let me give you a very quick review of the attachments. Medial one third, anteriorly pec major, superiorly clavicular head of sternocleidomastoid, inferiorly subclavius, and medially costoclavicular ligament. Around the medial end, the capsule for sternoclavicular joint. Laterally, anteriorly deltoid, laterally, posteriorly trapezius muscle, lateral one third, inferiorly conoid tubercle and trapezoid ridge for those two, and then the margins of this articular surface for acromioclavicular ligament. So this is all about the structure and attachments of the clavicle. Let me get back to the presentation. If you talk about the clinical aspects, it is one of the most commonly fractured bone in the body, and these are fractured when you fall face forward, try to catch your fall with your hands, and the fracture is happens between the medial and lateral parts of the bone. As you can see, as the bone is fractured, the weight of the bone upper limb, it pulls the lateral fragment downwards, and the attachment of the sternocleidomastoid, it pulls the medial fragment upwards. So these are separated from one another, and this is the displacement that you need to remember. And that is why when a person comes you with a clavicle fracture, you give them a sling so that the sling can bear the weight of the arm and the two ends can be at the same level with one another. And we talked about the ligaments, sternoclavicular, costoclavicular, and coracoclavicular ligaments. There's this ligament and here this one. They are so strong that they prevent the dislocation from happening. Rather, the shaft breaks in preference. There are shape differences. If a person is a laborer, hard worker, and doing more physical work, the bone curvatures will be more prominent, and their attachments of the ligaments and the muscles will be more prominent. Sometimes this bone has supraclavicular nerves. These are the nerves that are passing from anterior aspect of the clavicle to the chest. They pass over and towards the front of the chest. They pass through the clavicle rather than above it. This is one of the variation that can be found. Embryologically, it develops from two ossification centers. The two in the shaft that develop as early as fifth week of intraembryonic life. They ossify, they fuse with one another immediately within a week or so, and then they ossify to form the shaft, and then at the second ossification center is usually formed at the sternal end. And this ossify with the rest of the bone in your 30s roughly. So sometimes what happens is that these two primary ossification centers which had to join early in the life, they do not join and they become separated. So they become separated. So the clavicle, it's like an artificial joint that is created between the two parts of the clavicle. Or maybe you can perceive them as fracture. So, and sometimes this clavicle may be congenitally, partially, or completely absent. When this is absent, there is no bone keeping the shoulder away from the axial skeleton, and if you push the shoulders together, they can be easily squeezed together like this. So, this is called cleidocranial dysplasia, this absence of the joint. This is called and this is called congenital pseudoarthrosis, the partial absence, because this is congenitally pseudo joint is formed between the two. So this is all about the clavicle, and thank you so much for listening. I hope it was useful for you. I will try to keep the upcoming lectures more precise and more info. If you have any suggestions or questions regarding this subject, please mention in the comments and keep following for the next videos. Thank you so much. See you in the next lecture. Allah Hafiz.